So I'm excited to be here, and thank you for having me. Thank you to the network for funding this important work. I am currently at Mass General Cancer Center as a postdoctoral fellow, but this work was done during my doctoral training with Mike Antoni, and he is the principal investigator on this study. And the funding really supported my ability to carry out this work with Dr. Antoni and supported my dissertation. So distress in breast cancer, we know, is persistent and interfering for patients from diagnosis all the way through survivorship. About 25 to 30% of women experience clinically significant levels of depression and anxiety, so stress is a big deal for them. Cognitive behavioral stress management, which I will demystify for you in a moment, reduces distress and improves psychological adaptation as well as physiological adaptation in the short term post-surgery. So what is CBSM, as I'll call it from here on out? CBSM is a multimodal intervention that combines both cognitive behavioral therapy and relaxation training. So the cognitive behavioral therapy components include cognitive restructuring, the idea that if we appraise stress more accurately rather than immediately go automatically to the negative or the over positive, that we might be able to better manage the events that come up in our life. So we're reappraising stress. We help women cope more effectively by increasing their perception of controllability while a stressor arises. We also give them tools to increase assertiveness skills and social support training. So a lot of people here today have spoken about social support and optimizing social support. So we really go into detail with these women, the differences between tangible, emotional, and instrumental support, and helping them to brainstorm where they might be able to get more social support and matching the type of social support with the source of social support, which has been shown to be important as we optimize these support networks. So the CBT components help them and are really tailored towards the breast cancer experience. So these examples are very relevant for what these women are going through treatment. And the relaxation training is kind of a sampling of different types of meditation and mindfulness and relaxation, progressive muscle relaxation, guided visual imagery, and it gives them kind of a tangible tool to cope more effectively with the stress as they move through treatment. And we did this in 10 weeks. Again, post-surgery, so 2 to 10 weeks post-surgery, and women were in, this is group-based, so they participated for 90 minutes per week. We compare this to a one-day psychoeducational control seminar, which is a little bit more of a self-help seminar. They received the CBT materials, but they were not given any opportunity to kind of practice or taught really how to implement these skills. What we showed was in the short and some more long-term effects recently was psychologically women who were in the CBSM group had less distress, less cancer-specific anxiety, so intrusive thoughts related to uncertainty or fears of recurrence, greater positive states of mind and benefit finding. We showed that they had less depressive symptoms, which was sustained at 5 years post-enrollment as well as 11 years post-enrollment, and improved quality of life that was also sustained at the 11-year follow-up. And physiologically, we showed that women, so we had measured salivary cortisol as well as blood samples at baseline, 6 months and 12-month follow-up, and women had lower afternoon serum cortisol, greater Th1 cytokines. They had downregulation of pro-inflammatory encoding genes and in genes encoding for metastases, and upregulation of glucocorticoid receptor expression and type 1 interference response genes. And what I'm excited to share with you today, which Susan mentioned, is that we recently and just this morning found out that our next kind of looking into this in the short term, we found that women in, and I should say first, this is from Mike Antoni's group with collaboration with Susan and Steve Cole and published by my colleague Laura Bouchard. So we showed that women in the CBSM intervention had lower leukocyte CTRA over 6 to 12-month follow-up as compared to the control group. So we've heard a lot about CTRA and the kind of adverse response profile, and I think this just kind of adds to our understanding possibly of looking at those mechanistic pathways. And there's a part B to that, but I'll save that for the end. So essentially, knowing that we have both psychological and physiological findings in the short term, we wanted to look at this model for psychosocial intervention effects on adaptation and biobehavioral processes on clinical outcomes long term. So we looked at, does this CBSM intervention, which intervenes on these psychological, behavioral, and interpersonal processes, influence clinical outcomes, given that we know that they have improved psychological and physiological adaptation in the short term? To do this, we collected long-term data. Women were enrolled between 1998 and 2005 in this study. So in 2013, when we collected this data, they were between 8 to 15 years post-enrollment, with an 11-year median. So we collected data on whether the women had passed away, and if they had, what was the cause of death and the date of death, as well as whether they had had a recurrence and the date of recurrence. And we were specific that it should be a breast cancer recurrence rather than a new primary tumor. And we examined group differences in all-cause survival, all-cause mortality, breast cancer-specific mortality, and disease-free survival using Cox proportional hazards models and Weibull accelerated failure time test. So we had screened 502 women. We had about a 50% accrual rate, and so I can speak more at the end about the difficulties and challenges with behavioral interventions and recruiting at this time period, and the many appointments that women have to go through, in addition to being told perhaps they could attend 90 minutes per week of a stress management intervention for 10 weeks during their treatment. So it's a lot to add on. But we did randomize 240 women, 120 each, to the control group and the CBSM intervention. As I mentioned before, we baselined them. They either received the one-day psychoeducational control or CBSM. We followed them at 6 months and 12 months, and then we reassessed them at 5 years, where I showed the sustained depression effects, and then again at 11 years follow-up. So today, I'm going to present to you the findings from that final follow-up. And just first to tell you a little bit about the sample, these were women, again, they were 2 to 10 weeks post-surgery, earlier stage breast cancer, non-metastatic, but we did include women from stage 0 to 3. And the reason we included women with stage 0, ductal carcinoma in C2 or lobular carcinoma in C2, because even though they're not as likely to have a recurrence or die from breast cancer, and there's some argument that perhaps if they do, then they were incorrectly staged perhaps. But even though they're not going to have these same outcomes, they are just as likely to experience distress. And the levels of distress are not dissimilar from those who have invasive breast cancer. And so they were included in the original study. And so we included them in this. So women were about 50 years old. We had about a third of them were from a racial or ethnic minority. They were fairly well educated, most of them partnered, and they ranged from, I just looked this up because I forgot, 18 to 75 years old. So where the network was really instrumental for us was providing support for a lot of the legwork, because to collect this data was not easy. We had to go to the Florida Cancer Data System to link our data with the tumor registries. And so that required a number of approvals. And we also then had to supplement that data because women might have moved out of state, and we wanted to make sure that we would account for whether they had died and moved out of state. So we supplemented that with other death registries and online tools, obituaries. But for the recurrence data, as some of you might know, we don't have tumor registries on the state or national level for documenting recurrence. And Dr. Klein was talking earlier about the infrastructure to do some of this work, and I think that's an important factor to keep in mind, that we know about the onset of the primary tumor, but we don't know on kind of a registry level about recurrence. So that was more difficult. We did 240 medical chart reviews to collect that data, to comb through finding out whether or not women had recurred. And the network also provided us with statistical support and interpretation of our data, which we were appreciative for. So just to, again, remind you, we looked at these 3 outcomes, and we chose these covariates a priori to look at, to choose factors that we knew clinically would be likely to influence our long-term outcomes. So with these covariates in the model, what we found was that women in the CBSM group had a favorable advantage in terms of all-cause mortality. So here we're showing that at every point along this curve, the solid line is our CBSM group and the dashed line is the control group, that women in the CBSM group had longer time to all-cause mortality than the control group. Now, what we didn't see, although you can see our p-value, 0.068 is kind of approaching significance, but we didn't find a statistically significant difference in breast cancer-specific survival. And we also didn't find a statistically significant difference in disease-free survival, although, again, a p-value that might be approaching significance. So what we then brainstormed was, are we looking at this the wrong way because we're including these stage 0 women in our in our analyses when they're really not likely to have a recurrence or die from breast cancer, as I mentioned earlier. And you can look more about the details in this. This is published last year in Breast Cancer Research and Treatment under my former name, Stagel. So we did then a subgroup analysis looking at women only with invasive tumors, stage 1 to 3, and excluding those stage 0 women, we were left with 198 cases. Once we excluded them, I should let you know, we only had women that died from breast cancer, so we did not repeat our all-cause mortality analysis. We did find then statistically significant differences that favored the CBSM group, where the control group had shorter time to breast cancer-specific mortality than the CBSM group, and also differences in the disease-free survival favoring the CBSM group. So again, I think that's important to think about when we think about who are we looking at, as Susan mentioned, who are we tailoring these interventions to, and looking at what are the patients that can benefit most, and women with stage 0 breast cancer are not likely to have these same outcomes as invasive cases. So a little bit about considerations in future research. I think it's really important to differentiate. Our sample was non-metastatic, and a lot of the work that's been done previously and some of the difficulties in replicating some of the previous work were specifically in metastatic samples. And I've talked to a lot of people about this and kind of brainstormed, because some of you are familiar with Barb Anderson's work from Ohio State, and our sample and intervention is probably most similar to hers and kind of most likely replicates what she found. And I think it's important to think about, when we look at these biobehavioral pathways, do we maximize our chances of finding an effect when we're looking at a non-metastatic sample, where we're buffering the effects of stress in preventing metastatic processes rather than halting metastases once they've begun, or reversing metastases once they've begun. And so might we be more powered, in a sense, to do these interventions and affect clinical outcomes in a non-metastatic sample. However, the disadvantage of using non-metastatic sample is that you're not as likely to have these events that are your outcomes. And so you might struggle with power issues and would really want to expand your sample size so that you can detect the effect. Also, I think it's important to note that in the time that this study was enrolling in the 90s and early 2000s, we weren't being as specific about who we were including in these trials, and it was a little bit more of a all-comer. Anyone can benefit from stress management. And while I think that might be the case, we should also be specific in future studies in really recruiting women who perhaps do screen in at a certain level of distress, because those are the women that can benefit most, and then we're most likely to see the benefits of our interventions. And in examining potential explanatory pathways, I had mentioned there's a Part B to the paper we published today, and that is showing that increased CTRA was associated with disease-free survival. So there is some, there are some connections that we can possibly draw if CBSM is both decreasing adversity in self-report and decreasing adversity based on the CTRA response. So, linking up these exploratory pathways. I'm getting some confused faces. Did I say that backwards? Yes, I'm sorry. Yes, of course. Yes, I was wondering why I was getting some confused looks. Yes, so decreased CTRA. And so, right, so there's a connection here. When we look at explanatory pathways, we do want to be more thoughtful. Some of this work, because and we talked about this in our group yesterday, this outcome wasn't hypothesized back in the 90s when this study was conducted, and so some of the samples we have a lower number of cases, and so we have to be thinking about what do we want to look at so that we can make sure we have all the tissue samples, blood samples that we need to do this type of work. And we also want to make sure to expand generalizability, although like I mentioned, we had a third of patients were from a racial or ethnic minority, which I think, being in Miami, that definitely helped us, but we need to think about multi-site and more community recruitment for that type of work. And long-term, I personally administered some of these interventions not for this study, but for Mike Antoni's follow-up study looking at a 5-week intervention, and really saw how these women took the tools that they were given and applied them to their current situation. So I'm a believer that this really does have an impact on for these women in their lives. And what we're showing here is that it also has a long-term clinical benefit, and I think that's really important when we think about the implications for integrating this type of work in a cancer care setting. Again, this was 10 weeks, but recently we showed that doing a shorter intervention at 5 weeks also had benefits for depression and cancer-specific anxiety and less social disruption. So there is a way that we can do this in a shorter span, in a smaller dosage, and still have women benefit from it. And when we think about promotion of survivorship care planning, which there's a big emphasis on that, I'd like to remind you that when we think of survivor care planning, we think of what can we do for women when they are survivors. But this is showing that post-surgery, we can do something for them that will then affect their long-term trajectory into survivorship. And so why not get in there earlier if we can, if it's going to be beneficial? So I'd really, again, like to thank the network for providing this funding, and the principal investigator and my former mentor, Mike Antoni, and forever mentor, co-investigators, our colleagues and collaborators at Miami and around the country, and the network steering committee, our statistical support, and especially the study participants. Thank you.